We are.
We are live.
We are live.
The banner's not working for some reason.
See what? No, Ben.
Yeah. Hey, Megan. How you doing today? Got it right this time. It's my dad and stepmom.
Really?
Yeah, from Arizona.
Mr. Davis?
Yep.
Hey, Mr. Davis. And
Mrs.
Davis.
This is Tim.
I'm Tim, Mr. and Mrs. Davis. It's a pleasure to be speaking to you. Or about you. I'm sure you. Yeah.
Megan's feeling like a new human. Is that because you're in our company now or what?
Do we have that sort of power?
I don't know.
Megan will tell us.
Like always, everybody share.
Please share.
Start those watch parties.
Watch parties are great.
Yeah.
Very helpful.
It's going to be an interesting one today.
I believe it is. I believe it is. Let's start making sure here.
We're just
Everybody
tagging
knows.
people. Do the same. The flu has left your house.
Says who?
Yeah, who said that? Don't be coughing in here.
Yeah, we get enough of that from me.
Keep it going. Tag some people.
Please tag some people. It's going to be a super show.
Super duper. So they say.
So they say.
Let's go. Get them shares out.
Share, share, share.
Start that watch party. I know there's a lot of people need to hear this one.
I think so.
I want to ask what the weather's like in Arizona.
Probably awesome.
Probably. Let's go. Let's get them numbers up. Got to get this message out there. Yeah, today we had to pick up a new monitor.
Oh, it's beautiful.
Yeah. The old one wasn't wanting to work with us.
Oh, I just take a bunch of folks there.
Oh, look at Tim go. Boom, tagging. Hey, Crystal, how's it going?
Hi, Crystal. And hey, Chris. How goes you? There he is.
We're getting up there. Got about 5 more minutes before we kick it off.
Come on, laptop. They're like, whoa, you're really tagging away, huh? It is flaking on me.
It's flaking on
It's
you.
flaking on me. Gonna have to throw a flag on it.
Throw a flag.
Throw a flag. Should I throw a flag?
No, don't throw it.
Not yet.
No.
We have red flags to keep y'all in line, just so you know.
Yeah.
We will throw flags on you. Here we go.
Bop, bop, bop.
It's a beautiful day in the neighborhood.
Bop, 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 bop. Everybody say hi, thumbs up or something if you're here so we know who's here. Thanks, man. We totally make your day. I love that. I love to hear that.
That's a wonderful thing to hear.
Hey, Rick. How's it going, Rick?
Bet you that's Nick. He likes to change up his identity.
Change up his identity.
Mm-hmm.
Hey, Jessica.
Jessica's here.
Jessica's here too.
All right.
You must be bored, Jessica. Hanging out with Tim and I
Must be.
on a Saturday night.
Right?
Hey, Earl.
Please share, everybody.
Hey, Earl. How's it going tonight?
Gonna make a big difference if you share this out.
Yep, make a huge difference. Hey, Katrina. Jessica, what's up, girl? Very much so, huh, Jessica? So you're bored and you're hanging out with us. Thanks.
Well, that must be pretty rough.
Yep,
Stoop this low.
I'm telling you. We're getting up there. It's good to hear, Earl. Everybody should be doing great. Time we got
6:58.
6:58. We got about 2 minutes. Our last one, thanks to you guys, reached over 13,000 people so far. 13,000 views.
13,000.
So we're getting up there, and it's thanks to you guys for helping us out, helping get that message out there.
And you're a part of this platform, so you're going to be able to reach the audience that we reach as that audience broadens.
Deputy D and Timmy G.
That's right. That's
Got it.
us.
That's us.
Which one am I?
I don't know.
I don't know either. I think she's making things up.
I think she's being politically correct right now.
Why is she doing that?
I don't know.
She usually isn't.
Right?
Her mouth is filthy.
Oh, sometimes I tell you.
That's a horrible thing.
Hey, Gigi.
Hi, Gigi.
David, what's up?
David joined us.
David's got to be a top fan by now.
David is a top fan.
He is.
No matter what anybody says, David's a top fan.
Hit those share buttons, watch parties.
Please
Let's go.
share.
Share it out there.
Okay, I have a question.
Oh, here we go.
How do I say your name?
Oh, you're looking at
Yeah.
is it Tabe?
Yeah. So I'm excited that you're in here. You seem like you've been looking forward to it, and you're going to have a lot to contribute. I want to know how to say your name correctly.
And Sarah Shaw's with us.
Yeah, look, I think
awesome.
They're friends.
They're friends?
They're friends.
They're friends.
Yes, sir.
They're friends.
Friends.
Yeah. Tave.
Tave.
Is that right? Did I say it right? Oh, MAT is her jam. Uh-oh.
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 We got an expert in the house.
Uh-oh.
Hope we know what we're talking about.
Hey, Josh.
Hi, Josh.
Josh, you're going to find this one to be interesting.
I believe you are.
Hey, Terry.
Terry's here?
Yep.
Hi, Terry.
Yep, you guys saying it right. All right.
Tave?
We got something right today.
Tave? I like it. Tave.
We got something right today.
That's right. You can call it a wrap. We don't have to Let's turn it off.
All right, so we're going to get started. Keep hitting them share buttons.
Please keep hitting those share buttons.
We're going to get started. But before we get started, we want to let y'all know that we want to remind you, actually, that we have our own Alexa skill.
We certainly do.
Okay, so you can download it, and all you have to do is say, Alexa, open Law and Disorder podcast.
Welcome to Law and Disorder. Now playing prescription drugs and addiction.
Law and Disorder, the podcast that gets real with addiction, recovery, and everything in between. Hear the 360 degrees with your hosts, Tim, Disorder, and Joe, Law, with guest speakers specializing in every field related to why you just tuned in. Welcome to Law and Disorder. And remember, recovery is possible. Tim and Joe, it's all yours.
Alexa, stop. So it's as easy as that to get all of our podcast episodes, right? So if you don't have that, you can find us on Anchor, Apple Podcasts, Google Podcasts, Stitcher. We're everywhere, actually. Check out our blog. We have a blog we're setting up. It's already up. There's a few interesting articles on there. Many more to come.
More to come.
Yep. It's simply go to lawanddisorder.blog. So you can find us there. Some good stuff. A lot of follow-ups and intros to some of our episodes and kind of what we're doing here.
That's right.
So today's topic is MAT, which is medical assisted treatment.
Correct.
There's quite a few different routes to go on that. Before we even get started, we don't want to portray that we're saying you should or shouldn't pick or choose whichever one. We're going to speak basically from our experiences. We don't have anything against any of them per se.
Right.
It's just we're going to talk about what we've experienced, and we'd love to hear from you in the comments what you've experienced.
Yeah, we're open-minded just by sharing our experiences. What we're hoping to do is encourage you to share your experiences. We're not even looking for a consensus. Really, what we're looking to do is gather information and gather stories so that people who are in need can listen in or watch and hopefully choose a path for them, or maybe find somebody in our community that we're building that they think could help them. So that's our goal, our agenda, and I'm confident we're going to accomplish it today.
I believe so. So when we start out with this, we're gonna just for those of you that don't know, we have a lot of new people today. We'd like to say welcome. Thanks for tuning in.
Thank you. Thank
Yeah.
you.
So before we even get started, the whole law and disorder concept, right? So I'm Joe. I'm a deputy from a local sheriff's office. I have a lot to do with recovery programs. And what the heck happened? Yeah. All right. We're back.
Woo.
So yeah, I have a lot to do with recovery in the community programs. I'm on the board for Families Against Narcotics, and I developed helped develop one of the most successful programs we've had in our facility for people incarcerated. Above that, I have about 23 years of experience. I'm currently working with the state of Michigan and DHHS on a lot of different things to help people go from in custody to rehab and eventually and hopefully recovery. That's where the law side comes in. And I'll let Tim give a quick rundown of where this disorder side.
Well, yeah, if Joe's the law side, then I must be the disorder side, which I am. I'll seize a comment that Joe made about having 23 years of experience in law enforcement. That's about the amount of experience I have being struggling with substance abuse. I'm also a board member for Families Against Narcotics. I'm the director of a small local nonprofit. Besides podcasting, I write a column. I'll also be contributing to our blog. So that's pretty much that in a nutshell. Law and disorder, we're just trying to provide different viewpoints, work together to
just get information out
to people, maybe entertaining just a little bit, especially during these crazy times. But when we do this, one of the things we're most excited about is opening ourselves up to hear from you. So it's not all about us and what we have to say. Again, it's about what we all together can contribute to this fighting this epidemic.
Because it takes all of us.
It's going to take all of us, that's
Right.
for sure.
So today's topic, MAT, medically assisted treatment.
Yes, sir.
So Tim, what are the 4 most popular ones?
Well, I'd say we'll start with what I think would be the oldest. That's methadone.
Yes.
Right? Methadone has been around a long time. The next one on the list, I think, is Suboxone. Been around nearly 20 years now in the United States.
Yep.
Then we have Vivitrol, which is much newer as far as the way it's being used in our country today, although it also goes back a ways. And we also have a new one, Sublocade, which is like a version of Suboxone that tries to mirror Vivitrol in the way it is administered.
Exactly. So, with that being said, I mentioned earlier the program that we developed in the jail. That one strictly revolves around Vivitrol. And you're going to see that I'm a firm advocate for Vivitrol because of the situation that I deal with. The people that come into jail, first of all, they're detox, right? They have no choice but to detox. So they're completely clean of all substances. That's where I'm going to say I speak from, right? So for someone to go from that being clean of all substances for whether it be 30 days, 60 days, 90 days, and then to go back to something like Suboxone, methadone, or any other medication, okay, to me, that's like kind of going backwards. Now, I say that because I've seen the results of Vivitrol. Recently, we've given over 35 injections. And out of the 35, only, I think right now we're at 4 have come back. 2 because they relapsed. The other were unrelated incidents. So the success rate that we're seeing is extremely high. So when I say I'm an advocate for Vivitrol, that's my point of view. That's my experience, right? So with that, and I don't know if you all know how Vivitrol works, but we're going to kind of go through each one. And we'll start with Vivitrol. It's a blocker. It'll block those receptors, kind of fogs them over, so your cravings are going down. The whole purpose of that is to allow you to go to therapy, to continue making your appointments, look for employment, get assistance for whatever you need. I always like to say it's the key to the toolbox, just because that toolbox has always been there.
Right.
It's just allowing you to go
Have
further
access
into
to
it.
it.
Yeah.
Sure.
So, and then with that, I'll pass it over to Tim, and he can talk a little bit about Suboxone.
Okay. Well, Suboxone. Let's talk about that for a minute. Suboxone is what they call like a partial agonist. It is a scheduled drug, but it is great at eliminating withdrawal symptoms when one is trying to detox from a harder, say, street opiate like fentanyl. It definitely serves its place. It can be used for the short term to help one get through that. It can also be used in the long term with a similar, usually, goal of that one would have with Vivitrol. When you start taking Suboxone on a regular basis, hopefully you're also going to therapy and doing, maybe hitting meetings and doing different things so that you're moving forward.
You're functioning where the way you should be.
Yeah, it enables one to like resist a lot of the behaviors that go along with the obtainment of street drugs. When one has Suboxone that they can rely on, and if they use it correctly, they won't be out there stealing. They won't be out there doing the sorts of things we tend to do in order to get high. So it's definitely a great thing. It can help somebody out of a very dark, dangerous time in their life. I encourage people to take it. But one of the things I think we're going to realize over the course of this show is that there are different solutions, and there are I would make different recommendations to different people depending upon the circumstances in their life. So is Suboxone a good solution, a good like medically assisted treatment? It can be.
And that's the big key that we have to remember is we don't. Hey, Lori.
Hey, Alex.
Yeah, everybody's piling in. Okay,
Sure.
so as we're talking about this, we have to be open-minded as far as like we'll use Vivitrol for example. Not everybody's can take Vivitrol because of certain medical issues that don't allow them to, right? So in that case, that wouldn't be recommended. There's other cases where someone's willing to go detox, but not just cold turkey, right? So that's where Suboxone kind of comes in, eases that process, right? So there's a lot of different reasons, and we would never discourage any of them.
No, definitely not. So how about we talk about methadone for a minute, right? So we can touch on all of these, and then we'll do Sublocade.
Right.
So methadone is the oldest, to my knowledge, at least the oldest of these medication-assisted treatment programs that you're really going to hear about. It goes back into the 70s. In fact, I think the early 60s, if I'm not mistaken. It's a little bit easier to abuse, right? Suboxone functions in such a way that there's a ceiling on the drug. If you use X amount, that's it. Any euphoria or any thing you might feel that might want you to abuse Suboxone gets capped. It's for that reason. It's less dangerous. You're less likely to overdose. You're less likely to abuse it. Methadone is something that, again, it was a great thing in the 60s, right? A great thing for many decades, in fact. It was really the only thing out there to help people transition from that street life back into society. Somebody who was using methadone in a responsible way could get a job and obtain that job. So it helped, and it's for opiates specifically, right? So it helped many addicts for a very long time, and it still does today. But you see now that whole market is kind of being shared between methadone and Suboxone, and I think Suboxone has become probably the more popular of the two. Yeah. Suboxone is something you can get from a prescription from a doctor and pick it up at a pharmacy, whereas methadone you tend to have to go to the clinic on a more regular basis. It's a slightly more intrusive way of trying to use one of these drugs. So I don't know, did I leave anything out? that you would think of about methadone?
No, I think back in the day, with all the clinics and stuff, they also tried to incorporate that accountability because you had to go to the clinic, you had to report, you had to bring your ID. So there was some sort of accountability, but that's progressed now to where your therapy, your drug courts, and stuff like that are your accountability factors that are thrown at you if the law is involved, right?
Right.
Yeah. So going back on Suboxone, I think the big issue is if people are going to use it as prescribed and are making progress and doing it's a wonderful tool.
Sure.
It's that danger where there's a street value to Suboxone.
There is.
And
There is.
that's that temptation where you have Sublocade and Vivitrol. They are injectable, right? So it's every 30 days you get an injection. You're not relying on someone who's struggling with addiction in early recovery stages to get up every day and take that Suboxone or whatnot. It's there, right? Yeah.
Right. Once it's
Big
into
difference.
your system, you just move forward with your daily life.
There's no choices every morning.
Right. It's
Yeah.
no choices. You're not like tempted to say, I'm going to not take these
I'm going to
methadone
sell
pills
this
today.
to get this.
Right.
Because that would be a red flag.
That would be a red flag.
right?
Absolutely.
So that's not something you want to play with, right? And it's, again, situational. And that's where a lot of times when I speak of Vivitrol, I see people that have come in and out of jail and they've tried the Suboxone and it's not working for them, right? So if they get a longer time period in jail, that allows their brain to kind of rewire. And that's where that Vivitrol comes in because they can't abuse that. There's no street value to it. You're not going to get it.
No
right?
tolerance, no withdrawal, no high.
Right. So I could give you a Vivitrol injection, even though it costs about $1,500, and you couldn't get a penny for it on the street.
Correct.
So that's the danger of a lot of these different ones. And again, it's situational. It depends on the person.
Right. Now I've done Suboxone and Vivitrol, right?
Mm-hmm.
And I had good experiences with both, but I did have a rough experience with Suboxone. So there is a danger with it that I personally want to point out. It is difficult to withdraw from. And I had no idea really how difficult it would be. I've since learned to compare the difference between, say, heroin and fentanyl withdrawal as opposed to Suboxone withdrawal. It's like the difference between a sprint and a marathon. And that has to do with half-lives and how long certain drugs stay in your system. I tried to go from 8 milligrams of Suboxone a day to 0. And I was setting myself up for failure. That was not Suboxone's fault. That was my fault for the way I tried to come off of it. Nevertheless, I think it's important to recognize things like that you have to be very careful with Suboxone or methadone, because while they have wonderful properties and can do wonderful things for people, I wouldn't go so far as to say that they're wonder drugs with no side effects or no flaws, or they need to be taken very, very seriously. The Suboxone withdrawal led to the most challenging time in my life. Frankly, it was a nightmare. And again, I want to emphasize that had I done it the way my physician suggested I do it and had a long, slow taper, I would have probably been all right. But because I didn't, and because I had that really, really rough experience, I feel that I must share that and I must acknowledge that. So anybody who's on it knows, or thinking about getting on it knows, that there is going to be a time where you're going to have to come off of it. And there is going to be a tough challenge with that.
Right. And that takes a lot. So that takes a lot. That's a lot of involvement from your physician who's prescribing it. Because I've heard a lot of times, and you guys correct me if I'm wrong, but I've heard a lot of times where physicians don't want to even they're like, oh, you're good on that dosage, right? Keep going because things are working. They don't want to deal with the potential issues or problems someone may have coming off of Suboxone. And that's a bad thing.
Yeah.
And that's only encouraging. But before we get too far, I want to say hi to some newbies here.
Newbies.
We got Serena.
Hi, Serena.
How's it going, Serena? We got
Welcome
Sandy,
back.
Deborah.
Hi, everyone. Good to see you.
There's
share.
Sam. There's Sam.
Hey, Sam.
The problem is they leave people on it too long. Yeah, that's
Where's that
what
coming
we're
from?
talking about.
Yeah.
Exactly. Yes. And that becomes a problem because again, you're dependent on a substance.
Yeah.
And as long as I guess there's a time where you have to say, okay, you need this to get through your daily functions, to get to therapy, to get all that stuff that you need, and help you along the road to recovery. But I think each person has to decide, just with all of them. It doesn't matter if it's Suboxone, methadone, Vivitrol. Each person has to decide when are they good, right?
Sure.
Even though Vivitrol is non-addictive, it still gets a gray area when you say I'm done with it, right? Do you have all this stuff in line? Do you have a job? Do you have housing? Do you have food? Do you have health insurance? All that stuff, those are life stressors, right? And no matter which one you're on, that makes it very, very complicated to figure out that time frame when you need to come off of it. And at that point, you're going into the unknown because now,
Sure. Yeah. And, I do think I see Serena made a comment and Tave made a comment. Serena said, however you maintain, and I'll paraphrase here, live, well, that's your shit. Live it and live well. I do think if you have somebody in your life who has struggled with addiction and they are using Suboxone to maintain, that's an opportunity to praise them because they're likely coming from a dark, seedy world and making progress. One of the barometers for success and recovery is how manageable your life is. And that's what those early MATs were designed for, to help someone manage their life and to live some kind of normal life. I would never, in the 12-step community, they say, yeah, Tave, if someone wants to use MAT instead of shooting dope and have a good quality of life, then they are winning.
absolutely.
And I agree because I've been there. I was living a much better life as a daily Suboxone user than I was as a heroin user who woke up dope sick every morning and then began to plan how they were going to obtain drugs. The things I did, like pawn my son's video game systems or steal from my grandmother, the horrible things I did in order to use. I couldn't maintain a job. I couldn't think about the future. I couldn't concentrate on eating well or working out, any of that stuff, because my entire focus was get high, use drugs. So yeah, I'm 100% behind that idea. I have come to see MATs as a sort of spectrum. You can see like the progression that's happening in the medications themselves, the improvements that are being made. And I also can see how an individual who gets into that spectrum today could use all of these eventually in order to have a good life and almost immediately a better life.
I think the key is, are you making progress? Like, are you not going backwards? Like, backwards would mean, are you selling it or not using it as prescribed? That's, I think, the key point. If you're using it as prescribed and you're making progress, going to therapy, looking for a job, mending relationships, and all that sort of stuff, I think you're winning. And I agree with that 100%.
Terry had a good comment. Expert practitioners have different theories on how long Suboxone treatment should last for, but there is no evidence to support the claim that Suboxone should be taken for a short period of time, as opposed to being maintained on it for the long term.
That just falls right into what we just said.
Yeah,
because that's going back to, is there progress being made, right?
Right.
You wouldn't want someone on it long term if they're not using it as prescribed or selling it or not, whatever. if they're making progress, and they need to be making that progress, and that's where you just said we're making advancements with all four of them, and all four of them require therapy groups. They're linking you with DHHS to get you housing, food, help you look for a job.
Sure.
And those are, without that assistance on top of you just don't take an MAT and you're like, I'm good, right?
Right.
That does not happen.
So what we learn in addiction is that the drug abuse itself is a symptom of the disease of addiction. So when you're on something like Suboxone, you're essentially treating that symptom, all-powerful symptom that tends to be so destructive in our lives. That's why it's important to get into therapy and to do things to like obtain work and housing and become a functioning member of society and rediscover what it's like to have a worthwhile life, because so many of us lose sight of that out there. Hey, Barb, by the way, I want to say hi to Barb. I'd love to hear anybody who's willing to share their experience with any of these MATs, whether it's Suboxone or Vivitrol or what have you. I've already talked a little bit about Suboxone and how it had it was helpful to me at a time, and then my own stubbornness and made it such that coming off of it was very challenging to me. Had I done it as I was encouraged to do, it would have been a different story, but nevertheless. So if you have been on one of these MATs, we'd love to hear your experiences. And I'll get into my experience with Vivitrol in just
a few minutes.
Yeah.
But before we get to that, we're going to say hi to Lori, Georgia. We got a bunch of people in here that are piling in.
We have a really good core audience that we're building. Like Georgia. Georgia's been there from the jump, and she's a really big supporter of ours. That's exciting to us, because as we get an audience, we get feedback and we learn how to do a better show and to provide just a better podcast to the listeners. So it's a great thing. We're very excited for all your support.
Yeah. So with your experience, you talked a little bit about Suboxone, that was a very difficult time coming off. That's you, right?
Mm-hmm.
That's you. That's not everybody.
It's not everybody. And
right.
if you taper off as opposed to just jump off like I did, your experience, you'll have a much softer landing than I did.
Yeah. Oh, absolutely.
Yeah. There's a way to set yourself up for success and a way to set yourself up for failure. And I opted to set myself up for failure. And a lot of that was just because of my ego, just thinking I got this. And that was a ridiculous thing to think, frankly, at that time in my life.
So Terry says she's been on methadone, Suboxone, and Vivitrol. Honestly, either were abused or sold everything except, of course, the Vivitrol. Yeah, there's no street value.
Hi, Shelby. So you've been on methadone, you've been on Suboxone, you've been on Vivitrol. What were the pros, Terry, of these for you personally, and what were the cons?
Yeah, because those are going to vary from person to person. And
again, for example, with me, by getting on Suboxone, one of the pros was that I was able to kind of concentrate on my relationships. Because of all the damage I had done in my addiction, I was on the verge of having my son stripped from me. My parents didn't want to talk to me, not really. My girlfriend was about to break up with me. I was able to kind of like get it together a little bit and give my loved ones reasons for hope, reasons to believe that I was serious about changing. And by doing that, I did make a lot of progress in my life. I was able to maintain a job, and I could go on and on. But I'd like to hear for you, Terry, what were some of the pros and some of the cons?
Because they're going to be different with everybody. While we're waiting for Terry to type that out for us, one of the things we didn't talk about was Sublocade.
Sublocade.
Yes.
This is, I think, the newest of the four
and probably the trickiest.
Probably the trickiest, but it's definitely, again, progress on that spectrum.
Sure.
Yeah.
Yeah.
You want to talk about exactly what it is?
Well, for those of you that don't know, and we're not medical experts by any means.
We are not.
No, but the general concept of it is it has the active ingredient that Suboxone has, right? It's a 30-day injection. So that means it's a long-term release over 30 days. So you're getting that, I guess you could say that opioid fill, but not just the same as Suboxone, but it also clouds those receptors somewhat. So you're getting like the best of both worlds almost, I guess you could say. So yeah, that's a 30-day injection. That's making its way around now as one of the more up and coming MATs. There's a lot of jails using it. It's rather expensive. It's about $1,700. So it's right there with Vivitrol. $1,700 an injection.
Wow.
Yeah. I don't know if it's covered on under Medicaid, but I would surely assume so. That's something we'll have to look into.
Probably so.
Yeah.
And we get back to the idea of if you're going to use Suboxone at this time, if Sublocade is available to you, and Suboxone is a combination of buprenorphine, I believe you say buprenorphine, and I'm blanking on the other one. At any rate, if you're going the Suboxone route, Sublocade, in my opinion, at this stage of the game, is the way to go, because besides kind of helping you do all the things we've already talked about that Suboxone does, you don't have to make that daily decision. You're not wrestling with the idea of, I'm not going to take my medicine today because I want to go use a street drug, right? You won't opt for a hardcore street opiate, because once you get that shot, that option's taken off the table for 28 days. So you don't have to 28, 30 days, however many days it is. So you're not wrestling with that. But
there are some key points too, and I'm not sure on Sublocade because I haven't looked into it that much, but Vivitrol, depending on the person, wears off. It can start wearing off around 25 days. And then we are relying on that person to make that decision. Hey, I got to call my doctor and get the pill form to bridge me over to that 30 days.
Mm-hmm.
So yeah, I seen a comment that from Sarah. She's on methadone almost 6 years, and she had her first taper. She had trouble with that because she rushed it. I think that's true with all of them. Like you rushed it, you went cold turkey, boom, for the Suboxone. I think also Vivitrol can be rushed. It can be, because you see that progress. Like, okay, I'm not using anymore. You may have gotten a job, but there's other things that you need to get in order. We always stress you need to get those short-term goals, long-term goals in line. Focus on them short-term. They have to be realistic and reachable. You can't set a short-term goal as something like buying a house or whatever. And a lot of people, they get those first couple accomplishments behind them, and then they're like, "Oh, I'm good," and they drop off the Vivitrol, and next thing you know, we're right back. Yeah.
Right.
And it's not a miracle. None of these are miracle drugs.
Sure.
They take a lot of work, a lot of time. And I mean, you didn't just become an addict overnight and ruin your life overnight.
You're not going to fix it and rebuild it overnight.
No. And it's going to be a process.
Like they say, you have to work as hard at your recovery and as you did at pursuing active addiction. Let's touch on this comment from Tave, who says, saying getting clean is assuming you were once dirty, which is very stigmatizing. Let's change our words. Now, I have to be honest. I do want to help change stigma. There's no doubt. It's not my priority, though. So the reason I say that is I'd like to hear what words you think I should use instead, because I'm comfortable with being called a junkie, right? It can be upsetting and offensive to me depending on who says it and the intentions behind their use of that word. But that's just me. I know there are other people who are in recovery who would be very offended by that. So I do think that is a goal for us to have, to work towards changing stigmas. I think that's a very good thing. It just isn't one of my top goals. So I would love to have you chime in a little bit more about that. And it's something I'll keep in mind going forward. And I will try to change out the terms I'm using at your suggestion, for sure.
So I want to hit on the one about with Sarah. Medical staff was unsupportive of tapering They use fear of withdrawals to keep patients long term. I kind of hit on that earlier, where that's where they know if they start tapering that off, there's going to be potential issues, right? There's going to be the withdrawal issues. There's going to be the phone calls like, hey, no, wait, we messed up. I need more. And they got to change the script, more work for them, right?
Sure.
Then there's like a lot of different things that could go on with that and affect them in their workplace, which is, I think that's changing somewhat now. It's totally up to you to decide if you feel your doctor is the guy for you or the girl for you. You can't just, with therapy, with anything, you have to match personalities, right? You can't have a conflict in personality
Sure.
and feel like you're being treated right or they understand you. That all goes hand in hand.
Right. Now, my experience with Vivitrol is that it's really the best thing out there for me. Suboxone helped me. I never was prescribed methadone. I did abuse it. And Sublocade kind of came out after I was done with Suboxone. So it was never really, the timing was never right for me to gain experience with that. Vivitrol, on the other hand, for me has been a wonder drug. As close to a wonder drug as I've ever had. I've taken a lot of like SSRIs, SNRIs, all the street drugs I've abused. And I can't say enough about how Vivitrol has really helped me. It's taken like the monkey off my back. I don't have the same temptations that I used to. It not only makes it so that if I were to use it, I'm not really going to feel high. It makes it so that I don't want to use. I don't wrestle with those cravings that I used to wrestle with. And when you're in early recovery, wrestling with those cravings can be exhausting because they can come fast and furious, frankly. They're more often than Fast and Furious movies hit the movie theaters, right? So Vivitrol has made it such that I can truly, truly concentrate. And we were talking about that with Suboxone, the way it kind of opens up doors to individuals to start moving forward in life and making themselves a comfortable, happy, manageable life. Vivitrol's really, really truly done that for me. I've been able to just concentrate on my job, concentrate on my therapy and just all the different elements of recovery that one needs in order to move forward. So for me personally, it's been an amazing thing.
So Tave, that's a good point. With the group that Tim and I work with, Families Against Narcotics, that comes up quite often as far as the terminology. Like I would never walk in as law enforcement or a board member or anyone and say, hey, listen up, you junkies. That would never cross my mind, right? So the thing that Tim and I have going on in this group is, and not just Tim and I, but Tim and everybody else, is he's the only one in recovery that's on the board, right? So when we have a crowd and we're doing our group meeting, I'm not going to be able to relate to them. Just as the terminology is not going to relate to them, they can't. They're looking at me like, dude, you don't know you don't know where we've been, right? So how dare I use the word? I agree with that totally. Where Tim can walk in and there may be, everybody's going to take it differently with the terminology, but I see a big push in the community, especially in like law enforcement, and it's the terminology is changing. You never hear junkie at our groups.
No.
We would never use it.
No. It is something that is condescending, right? Like there are words over the course of history where certain ethnicities have learned to embrace them because they were so hurtful that they tried to use those words amongst themselves as a means of empowerment. Same thing happened, I believe, with the gay community. There's such hurtful words that were slung in their direction. And one of the ways they learn to cope together with those words is to sort of embrace them amongst themselves so that when they say them to each other, it's much different than when an outsider says them. But it was trying to change the power dynamic with those words, right? So that's kind of what happened with me with junkie. I just kind of came to accept it. It is different coming from different people. I do think there is value in what Tave and other people are saying, though, about trying to get away from those words, find better terminology that's not stigmatizing. And yes, I agree that it's possible that doing so could save lives, Tabe. So it is something I take seriously, and it is something I will keep in mind. Again, though, one thing I'm looking for in these comments that I'd love to see is alternatives, right? Alternatives to those words. There's always, it's easy to identify a problem. It's a little bit harder to find the solution to that problem. So if you can help me with that and give me kind of a leg up on this, I will do my best to make those changes.
And I can always recommend, if someone uses a term that you don't like, just give them a friendly reminder like, hey, you know, I've been through this, or we've been through this. We probably shouldn't refer to ourselves like this, because, you know, the people that we may be trying to help that are coming into the groups and whatnot, they don't need to feel like that, right? And we've touched on that before.
We have.
Yeah. And it's all just like, I don't look at anybody in recovery as a junkie, right? We gotta
look at them as human beings with a problem.
You almost have to look at them like heroes, right? Because at some point, you'll take it. I know you will, but guess what? I have the Batman shirt.
You got the Batman shirt.
But anyway, that's how we have to look at people, and that is changing. Like, it's not. And we used to talk about the differences in law enforcement, how the times have changed, and it used to be years ago, decades ago, it used to be the junkies and this and that. It's not really that way anymore, right? That term you'd find used only if someone truly didn't want help or refused help. But anybody who's willing to get help, that terminology is not going to be used.
No, I don't think so. And what I'm hearing from Sarah and Tabe is person in recovery, right? Yes, I think that is a very thoughtful, diplomatic, appropriate way to describe someone in recovery, is as a person in recovery. And I'm not making excuses or trying to backtrack, but junkie just rolls off so much easier, right? I do wish we had like a word as opposed to a phrase that was in my mind, a better substitute.
Well, here's the thing too. You have to look at society in itself. Like something that happened today, right? So Tim gets a hold of me. He's like, hey, can you run me up to Myers, bro? And I'm like, sure thing, man. So we're driving, right?
We were
driving away, right?
To Myers.
Yeah.
We were going to Myers.
We come up to the light, and we watch this car go to make a left, but right into somebody. Like, we're talking inches, right?
Right.
And what do I say? The typical thing that most people would say, like, they must be on crack.
Did you? I don't remember.
Yeah, you don't remember. See,
but
after I said it, I was like, should I have said that?
Yeah. See, I wasn't offended, right?
See, but that's just him and I.
And I did have a crack problem.
But it did give me an afterthought of like, hey, should I have said that, right?
Yeah. No, that's a great example.
Yeah, but that's like just normal, like talk how people talk, like, and unfortunately, that's the way it used to be. Mm-hmm. And it's difficult to break away from that, but I think we are making progress.
I'll tell a story that sort of relates, right? We're getting off topic a little bit, but when we went to the schools and talked to the children, there was one group of kids, if not two, I might have done it twice, but I remember asking, can you tell me what a crackhead looks like, right? So I used a very stigmatizing term for a purpose. I'm not saying I was right to do it. I'm willing to rethink it. I'm willing to entertain the idea of not doing so in the future. But the reason I did it was so that, and the looks on their face were funny when I said that, right? And I think they started trying
to... Hang on. Is Amy here? Amy, you still here? Keep going.
Okay. So the reason I tried to, they started, I think, picturing like Dave Chappelle, right? The character he would play, free crack giveaway, dirty guy. And I'm pretty sure somebody said ashy. It was humorous, it was really intended to be a lighthearted moment. But my whole goal in that was to say, I am what a crackhead looks like. I did go on to say, actually, a recovering crack addict, a recovering addict. So I tried to walk that terminology back a little bit, but I was trying to get their attention with that word, A, to see how they would respond to it and to learn from their response, but B, to actually fight that stigma, to say somebody who is a crackhead or somebody who smokes crack doesn't always look like what you think they might. You know, it was a really I think valuable lesson for them, and it was certainly valuable to me to see how they responded to that sort of dialogue.
So Sarah says, yeah, that's a active user. It takes a lot of strength, and to go through recovery takes even more, especially those on MAT, because every angle, yeah, you are getting stigmatized. Yeah.
And, you know, I feel so badly for the, I agree with that totally, Sarah, that there are people who feel really, really good about themselves because they're not using heroin. They're on Suboxone now, and they're making progress, and they're reading the NA book, and they're going to meetings. And then people in those meetings are the ones who will stigmatize them. Sometimes that stigmatization comes from within the recovery community. That's what's so upsetting about it to me, is I find that most of that stigma comes from there, not from the family members who are watching this person change and have seen how low they've been in the past and seen how good they feel about themselves now. It's the people in recovery who have had some clean time under their belt and been around for a while, who feel like they have the right to say what you are doing is wrong or what you are doing is not enough. And that is a very discouraging, frustrating thing that I think we need to change within the community. Only we can do that. Joe can't do that.
No.
Our loved ones can't do that. That's up to us to change.
And I think that is true, that could be a negative. Like that, if someone who's in recovery considers himself a crackhead or a junkie, that's like planting a negative seed. And with anything that happens in life, any stressors or negative things, they water in that seed, right?
Oh, yeah.
So that temptation to go back to what you're identifying, you're identifying yourself with as that.
Right.
So at that point, it shouldn't be used. And like, I would never walk in and say, hey, listen up, you junkies, or, you know, we've been hanging out a lot, and I don't call him crackhead or anything like that.
Not to my face.
No, but, you know.
Yeah.
Man, why you gotta bring that up?
Well,
Yeah. But yeah, on the MATs, we got that stigma. We could actually do a whole show on that one.
Stigma. Oh, we should.
Yeah,
we
we
should.
should.
And if we do, we should definitely talk to Sarah and Tave, because they have a lot of thoughts on it.
Yeah.
And I think they'd make a good, be great contributors to that.
Maybe even a guest.
Topic. Yeah,
Maybe
yeah,
even
for
a
sure.
guest.
Yep.
So yeah, back on the MATs, what we want to stress, and the whole purpose of getting this out there today was, no MAT is bad, right? If it's used properly.
No, I agree with that.
And I think it's situational, as we mentioned before. There are medical reasons why someone couldn't do one or the other. That all has to be taken into consideration. I can't sit here and say I've seen high success rates with Vivitrol in the jail scenario, because there have been a handful that weren't able to get that injection prior to leaving the facility because of medical issues, right?
Right.
So I didn't just say, hey, well, guess what? It's Vivitrol or nothing, right?
Right.
We helped them along the way to get to a different MAT.
Sure. You gotta love people where they're at. Can't wrestle with them about, no, it's better to do it this way.
No.
If you find one who's thinking about making a good choice, it might not be the choice that you would make for yourself, but encourage the good choice if it's a good choice.
But you can always openly discuss that, right?
Absolutely.
Because and a lot of times, you know, I hear it a lot actually in the jail. In Georgia, you could probably hang on. Oh, hey, he's back.
He's back.
All right.
What's up, Rich?
But Georgia could attest to this. A lot of times they come in, they've been in jail for 30, 60 days. They're way past the detox period. Brains are starting to rewire a little bit. They're starting to get a grasp on reality. They're seeing, okay, lost this, and it's all negative. And the first thing they do is revert back to, I think I'm going to go back to Suboxone or methadone, and they don't want to hear anything about Vivitrol, right? Because it's something maybe they haven't heard about, or
it's scary.
Or it's scary because it's new, right?
Yeah.
And the scary part is it's non-addictive, right?
Well, yeah,
For a lot of them.
sure.
So then I just say, like, if you're made it this far and there's no medical reason why you can't take it, why not try it?
Try it.
Right?
Yeah.
And then they'll go back and say, nope,
try it.
nope, my mind's set on Suboxone, right?
Yep.
So then what do I say? Red flag.
You've been waiting for that.
I've been waiting for that. But that's a red flag for me that they truly don't want recovery. because they'll defend it. They're not open to discussion. If you're open to discussion, at the end of the discussion, you say, no, I feel Suboxone's right for me, I will agree with you all day long. But if you're not open to discussion, when there's a program in place, you've already detoxed, there's no coming down off of anything, right? And we can remove those cravings and get you set up with all the things you need to succeed. That's where it gets a little tricky from my perspective.
If you're in early recovery, you quickly learn to submit to a higher power, and it can be a sponsor or it can be a home group. It can be any number of things, but I had to learn that my thinking was sometimes the most dangerous thinking around. I had to learn to listen to other people who cared about me, allow them to represent a higher power and contemplate their advice, contemplate their experience, and stop thinking that I could do it all on my own.
You have to weigh it out. Like, I'm biased to Vivitrol. There may be a therapist or a doctor that's biased to Suboxone, methadone, or Sublic. It doesn't matter.
You prefer Vivitrol.
You have to just listen. And I think you have to make the decision based off of your own situation, your own medical situation, your goals. And that plays a huge role in the whole thing.
Yeah, absolutely.
There is no one and done.
No.
Right? There is no miracle drug. These are the purpose is in the name: medical assisted treatment. Assisted.
Right.
So
and I think the key word again is treatment. Right. When we say treatment, we think of things like rehab. Right. Every doesn't think the same way though, and there are different core issues factor in wanting to be out of it, even if you're pleased. So we can recover. I agree with that topic.
Yeah.
I do agree with that, and I think I understand what Joe's trying to say though too.
I'm saying they're repetitive.
All the work and you're sober, and you don't have any drugs in your system, which is a hard thing to do. It's a hard thing to it's a grueling process, detoxing from a drug. If you make it that far, he just knows from his experience, because of the program he sets up and the numbers he keeps track of, how effective Vivitrol is, right? So he kind of pimps it, and it's understandable because it's so successful in his experience.
And the ones that say no, and that's where I think there's some confusion. When they say no because they want to go back to what they left the jail on the last time was Suboxone, right? And it hasn't worked the last 3 to 5 times. It may be time to try something new, and that's where I'm coming from, right? I'm talking about repetitiveness, right?
Right.
So
and you get into this it's hard sometimes because you want to share what's worked best for you, and you just feel so strongly that it's going to work for this person if they only open themselves up to it. So we get passionate about it, and sometimes we have to. I know I've had to learn that I can't solve other people's problems. Nobody was able to solve mine. All I can do is help them solve their own.
Can offer help. And it's tricky, right? It can be tricky because once we get pulled in and we're emotionally invested in another human being, we so badly want to help, and sometimes we have our own preconceived ideas about what that help should look like. So I agree with you, Tave, for sure. Yet I understand completely where Joe's coming from, because I know how well it's worked for me. I don't think if somebody who's clean, somebody who hasn't used any substances in a while, decides that they want to go on Suboxone, I do think there are individuals to whom that means recovery, and there are individuals to whom that means substance abuse. Yeah. It really depends what their attitude and their motivation for going on that is, right? And where they're at in therapy, where they're at in life.
Yeah. Why do they want to do that? And I think if the reason they want to do that is because they feel that's the only way they feel safe, and the only way that they're not going to go back to the streets and live the life they were, then yeah, I get it. They're in recovery. They are recovering. They are moving forward. Maybe in a different direction than Joe or myself would like, but I definitely see them as being in recovery, just taking a different approach. And that's something we talked about. So I think even though there are times where there are these places where there's small differences in the way we would prefer to do things, I think really when we talk it through, we tend to come out on the same page. And I think that's what's invaluable.
Yeah.
It's just having discussion with people.
And I think, Sarah, you hit it right on the head. There will always be individuals that give Pathways a bad name. Not everyone does it for the right reasons. And with that, we'll leave that alone.
Right.
And we're going to hit on one more thing I seen in the comments in one of our ads for tonight's show was, do people consider someone in recovery clean, we'll use that term, sober, or in 100% recovery if they are on a medical assisted treatment?
Okay, so
that was one of the comments, one of the questions.
That is the most controversial thing that we could discuss under this umbrella, without a doubt. And it is something that is set meetings on fire. It is set groups, 12-step groups of fire, and torn them apart. It's in the NA book, if I'm not mistaken, that sort of question is best answered between you and your sponsor. It's really for no one else to say whether or not you're in recovery, right? Or if you're high, or, because when it comes to, again, in a book, it says something about no mind altering chemicals. But what's tricky about that is I took Effexor for years. And the reason I took it was to alter my mind, right? I took it in order to stabilize my mood. It was kind of a mind altering chemical. It didn't give me a high per se, but it did change my brain chemistry. So would that mean that I'm not in recovery? I think that's a fair analogy to make, is that it's really no one else's place to say that. I think it's more important how manageable a person's life is, what their motivations are, that sort of thing. Those are better barometers for who's truly in recovery.
Yeah, and that would be like me sitting here right now saying he's not in recovery because he's getting the Vivitrol injection every 30 days.
Right. And I would say, what the hell are you talking about?
Right, and that's complete nonsense.
Yeah,
right?
I haven't touched heroin and crack in a year and a half. I haven't touched Suboxone in nearly a year. You got a lot of nerve telling me I'm not in recovery.
Yeah.
Would be my attitude.
And I think Deborah brought up a good point, those underlying issues. If you're on an MAT and you're not taking care of those or attempting to those underlying issues, because a lot of times there's more than just substance abuse as an issue, right?
Sure. Oh, yeah.
Yeah.
Because it's a co-occurring disorder.
Right. And that's a whole other show.
A whole other show.
Right. But that is a very good point, Deborah. Those underlying issues also have to be addressed in the process of taking an MAT, because an MAT with without addressing those underlying issues is a Band-Aid over the wound.
Right. And some of those people in the Flint area will know the gentleman I'm talking about. Of course, I'm not going to say his name or anything, but you might know him based on what I'm about to share. He frequently would say in meetings, if the dope drove you here to the tables, if the dope drove you to the 12-step meetings, what you need to do is figure out what drove you to the dope.
Yeah.
You should not? Okay. Some of us are sicker than others, and that's another thing you'll find in the book, and it's true for sure. Some of us are sicker than others. Some of us need more help in different tools to move forward.
And I think it's very important that we stress again, there is no rubber stamp for recovery.
No, I wish there was.
Like, it's not the same for every individual.
No, we can't cookie cutter solutions and give, no.
It's completely different.
Yeah, we got to find that. Once you yourself get into recovery, me being in recovery, I now find it like, personally, I feel obligated to help people who are just now entering into the program. And the only way I can truly help them is to be open-minded about who they are and what they need, not to try to walk into that situation with preconceived ideas about what's going to work, but rather get to know this person, listen to this person, and then figure out how I can help. And that's the only way they're going to be successful, and I'm going to succeed in helping that individual.
And again, it comes down to that personality. Is it a match? Do they understand what you're talking about? You have to adapt sometimes. There's no sense in going to a therapist that you can't stand.
No,
Like-
I've been to so many, and
Yeah.
some of them I couldn't stand.
And you have to then make adjustments. You have to go look for another one, and you'll eventually find when you connect with.
And I have.
Yeah.
And I've found some that are great because they are out there for sure.
Yeah.
They are out there. They don't have to have experience with substance abuse themselves either to be good. I've had therapists who were in recovery themselves,
Mhm.
and I have had some who weren't that were just as effective. We never know. It's just like there not being automatic solutions to this problem. There's no criteria that makes one therapist better than another. It's more about fit. It's
Yeah.
more about experience, and being able to communicate with one another.
And I think it's we're making progress. I can see it in my place of employment. We like to think that we're ahead of the game. That's part of the reason the state reached out to us, and we hope that part of it can be streamlined. And I think that's what it's going to take. Like, if you have a state doing something, the federal government wants to do this, cities are doing this, counties are doing this, this agency's doing this, then they all have faults, right? They all have their specific faults, and nothing's getting fixed.
Right.
And I think when they all come together, we'll be able to weed that out, streamline things to where there's options. There's way more options, right? And MATs are going to be a big part of that, as well as the counseling therapy.
MATs
And-
are going to remain a part of this going forward.
They have to.
They're only going to get better. So yeah, it's just like anything else. They're going to be around, so we need to talk about them. We need to fight the stigmatization of them. Learn to embrace them and learn where and when it's appropriate to apply them.
Exactly.
Thank you, Sarah.
Thank you, Sarah.
Before we go, Joe, I think we should mention our Monday show real quick.
Yes, we're gonna on Monday. I dropped the link in our last show for Katie Donovan. She's going to be our guest. Obviously, we're going to do it remotely because we have to practice social distancing. Like, see, that was 6 feet. But yeah, she's going to be remoting in, so we'll have her on camera as well. Mother of an addict.
Mother of an addict.
She's
She's talked to groups. She's been around.
She's traveled.
Really, sharing
she's
her message for a long time.
an author, a motivational speaker,
Yep.
and a life coach. So with all that, we'll definitely get her in here on Monday. We're looking forward to that. It's going to be a great show. I'll drop her a link to her page in the comments when we're done here.
We're looking Monday at 7:00.
Monday at 7:00.
I'm really excited about it. I love when we are able to do this. You and I are able to wrap back and forth and incorporate the comments into this. But I also love talking to guests and really zeroing in on an individual who has a lot to share.
Because again, we can't be us without you.
We cannot.
No. And with that, we're going to wrap it up. Don't forget, check our blog out. Our actual podcast on Anchor,
Yep.
which just throws it to every platform you can imagine.
Yep.
You can
Get the notifications from the Facebook page.
Yes.
So when we go live, you're aware of it.
Yep.
Please share. Every time you share, whether you're sharing while we're live or sharing after the fact, it's going to help us broaden our audience. It's going to not only help us reach more people, it's going to help you reach more people. It's going to help us together reach more people and hopefully change lives.
I like that. Law and Disorder Lockdown Edition. Oh, that's a good one.
That's right.
That's a good one.
Yes.
All right, with that, we're going to peace out.
Thank you so much.
Thanks for tuning in.
Yeah, it really, really means a lot.
And remember, share us after we hang up here.
Share.
Share,
Sharing is
share.
caring.
Keep your space. Wash your hands.
Yeah.
And if you need anything, dial us up. Send
Yep.
us a message.
We're
We're
very
here for
accessible.
you. We're very
Very
accessible.
accessible. You can write emails. We're there.
All right. Thanks, guys.
Thank you so much.